And Tom, thank you very much. I know you're making time for us today, and we really appreciate it. Appreciate all of you bearing with us with the technical difficulties. In addition to all the technical things that can happen, sometimes your gardener shows up at just the wrong time. So I want to thank you for that. Well, welcome, Tom. Really appreciate you joining us. The purpose of our talk today is talking about upskilling your workforce. And, when we talked in the pre-call, you were talking about the need to do that. And can you kind of put some parameters around what that means and how you define that?
Sure, and thanks for having me on. So, I've had the privilege of working with health and medical leaders around the world for at least the past decade on AI and digital initiatives. And, as hot as the topic is of AI, as many people are out there talking, writing about it, it's just interesting to me that a lot of people are talking and writing, but they've never actually worked with it. So from my perspective, through the years, when I look at which organizations are making big investments in AI, and yet if I come back 2 years later, they're really not getting value at scale. The number one issue I often see in what's driving that, and it has nothing to do with leadership commitment, budgets. I mean, they've done the right things, they're just not getting value. It's typically one of the top things is what I call the inertia of the workforce. So you may have 100 people at the top of an organization that are bought in and are investing, and you've got thousands of others who have to be brought along. And in saying that, I quickly point out it's not the medical staff's fault. It's not the nursing staff's fault. It's the fact that driving value at scale with AI and digital requires us to think and act differently. And so many times what we see is AI gets put to a blue ribbon panel, a data science group. And meanwhile, everyone else who are on the front lines providing nursing or medical care, they're saying, well, what does this mean to me? So our ability to bring everyone along in the journey is a key part of driving value at scale. And many organizations talk about digital transformation or being innovative, but they're missing the key factor, which is, that happens when workflows change. Who drives workflow? Well, it's not the CEO. And yet the CEO has a huge role when it comes to their responsibility for doing certain things that oftentimes don't happen.
How do we'll get to the CEO, but how do you encourage? You spent 15 years approximately at Microsoft in AI and life sciences. How do you suggest to leaders that they bring that vision that the CEO has down to the front lines? And how do you suggest to them to bring in literally everyone, from the person that's changing the linens and the trash, to the nurses, to the RNs, to the doctors? How do you get them involved, and what is it that they're not doing now that they should be doing?
Well, almost before I answer that, I almost feel like I need to pull back and maybe talk about what I call some primer issues. So, and I'll get back to that in a second. So, if we look at the higher levels of the organization, we look at groups like, people who are highly trained knowledge workers like physicians. So a report by Stanford says today physicians spend more time doing administrative work than they do with patients, which to me is just wrong. When you look at the fact that we've got a physician shortage, we've got a huge issue with burnout, with these repetitive activities contributing. So on one hand, they're doing more in administration many times than seeing patients. There's another study by McKinsey that says up to a third of all repetitive activities that are done by nurses and doctors could be automated with AI. So if we just tease that out for a second, what if we could go to physicians today and say, what if I could give you a third of your time back to play to either a higher value for seeing patients, doing research, or even doing something simple like getting home for dinner more often with the family. So those are all the things that are possible. But many times what we see is we see AI being treated in healthcare as a technology initiative. And to me, AI is not about technology. AI is about empowerment. So our ability to, first of all, decide which use cases are the best to be using AI for in the clinical realm. I mean, the groups I always want to go to first are the ones on the front lines working with these processes every day to say, what are the things that if you could be better at, you would change? That's the starting point. Looking at what are the use cases, looking at then bringing in the smart people who do things like Lean Six process design. But to me, it's a process, but it starts with looking at the high level issues and then backing into a process that helps create change. Um, so the second thing I'd say is, if there's anything people remember about, this podcast is simply, it's interesting to me how many organizations also are investing in AI. And yet, if I ask the leaders how AI principally drives value that can be measured, oftentimes don't get good answers. And so there are only two ways that AI can drive value in a healthcare organization. One, it either automates the way work is done or it augments. Now, it automates, and I'll come back to your point now. You mentioned housekeepers. So there was a headline in the LA Times a couple years ago where the housekeepers at Kaiser were going on a 1-day strike to protest the introduction of robotic vacuum cleaners. So automation means something that's a position that's highly repetitive, not a lot of variance, not a lot of problem solving. Those are the jobs that will likely get automated out of existence. Now, having said that, let's stay with housekeepers for a moment. That doesn't mean we're going to eliminate all housekeepers. What that means is there'll be fewer actually mopping the floors or vacuuming. Instead, that might be replaced by a robotic vacuum that has AI inside to guide it. We still need their expertise on certain things, number one. Number two, we already have a huge workforce shortage
Yeah.
across the realm. So imagine a healthcare organization, if they're automating something, going to that same group to say, hey, we want to do some additional training to actually upskill what you do. So instead of a housekeeper, you become a nursing assistant, you become something else. But we pick a channel to take these people and we actually move them in a direction that's good for them, good for the organization. So that's automation. Augmentation is where most of the value comes in healthcare, which is where we take the things AI is better at than humans and bring it in behind those clinicians, any knowledge worker, to make them better at what they do. So when you understand it either automates or augment, now you can start looking at, well, which positions, which roles, which activities really are ripe for automation with a plan for upskilling in another direction, or if it's augmenting the work of a clinician, then the upskilling really there comes into one, helping them understand even the components of what AI can do. And then second, engaging them in a process where they're helping to drive the best use cases that are going to create value. And eventually you do enough of those, it creates value at scale. I know that was a long answer, but that was kind of a complex question.
Yeah, no, that totally makes sense. Carolyn, did you have a question? I have a follow-up, but I wanted to see if you had a question you wanted to lob in here.
All of this reminds me a lot of Crossing the Chasm by Jeffrey Moore when we think about AI adoption. And I love thinking about, I always come back to it when I think about technology adoption in general. But I would love your thoughts, Tom, on how it applies in the space of AI right now. It feels like we are in a place where there are a handful of early adopters. And as you talk about, like, you need to identify the specific areas where we can make workflows faster. Like, how do you recommend accelerating getting from early adopters to the general mass using AI and get over that chasm?
Well, I think that's what I would call the leadership imperative. And once again, the number of organizations, I mean, today, and particularly if there's any good news about the pandemic, it helped expedite the use of AI in health and medicine. But today, pretty much every organization is using some form of AI in health and medicine. But again, the difference is, coming back 2 years from now, even 12 months from now, to see which ones are truly driving, they're creating that flywheel. They're driving value with scale versus the ones that are going to be talking about 2 years from now, the use cases they're proud of that, they facilitated 2 years ago. So much of that is what I call the leadership imperative. And I was kind of touching on it earlier. You have to look at AI as a tool for process change. When you look at what it takes to do process change and things like, you're pointing out things like crossing the chasm, what we're looking at is change is all about leadership. Leaders, leaders are responsible for driving things like culture, driving the vision, getting things out of the way so those underneath can not only understand the vision, but help, they get to help put their hands on the steering wheel. And maybe it's just a finger on the steering wheel, but they get to help drive the planning and execution. When that happens, which is a leadership imperative, it's a style, that's where we see organizations starting to drive value at scale. I've had this conversation before with leaders, and again, there are no bad players here. It's all about everyone, including when I talk about the need to be doing digital and AI upskilling. It starts with the C-suite. And again, Gartner and others point out that you can be a great leader that's been very successful up to this point if you believe in AI and digital transformation. Being a leader in that new realm requires new hard and soft skills. And so your ability to think you're going to have the same skills as a leader to be successful going forward, it's not the same. So I've had this conversation with C-suite leaders before. I love asking CEOs, what's your role in AI? And oftentimes the answer starts with, well, I've hired the best CTO I can find. I've let the budget committee know that this is a priority. When I hear that, that tells me, no, they don't get it. The CEO is responsible for things like setting the vision. The person that really helps start driving a different culture. That inclusivity of saying, on my blue ribbon panel, I've got 2 physicians out of 20, but I've got 2,000 physicians on staff with privileges. It's how do you bring those other physicians along? And many times, I was asked on stage a couple months ago by someone. They started their question by saying something like, "Well, we all know physicians are change resistant." And before she could even finish the question, I stopped her because I didn't want to be embarrassed by answering her question. And it's like, here's the thing: physicians are as human as anyone, believe it or not. And like anyone, when they see something that they don't understand and they're not being included in, they drive home like all of us saying, well, what does this mean to me? And if we're not bringing physicians and everyone along, and they're asking that question of what does it mean to me? And they're reading all of the things in the lay press and the professional journals about how first we're all going to lose our jobs and then we're probably going to be enslaved by AI. I mean, it's no wonder that people are resistant. Which brings me back to, part of that digital upskilling is bringing everyone along, starting with educating them on what AI is, how it eventually can be used to not only be a threat, but actually be a tool to, again, free them up from the repetitive activities. I love Eric Topol, who many people know, head of Scripps Research, author of a really great book, Deep Medicine. He termed the phrase keyboard liberation. I mean, when you look at what we've done to clinicians, they went to medical school or nursing school and we're turning them into data entry clerks. So our ability to start moving in that direction, but having people understand that in the end, it is going to impact how they work, but hopefully it's going to make them better at what they do. There's another study that just came out from Science Magazine where they really a good evidentiary test where a simple test where they had about 500 knowledge workers, half were given GPT. They were all given the same writing and knowledge tasks. And the study reported not only, those using generative AI were far more productive, but it also reported that those using it and their ability to do work faster and be more efficient actually gave them greater job satisfaction. So those are the things I look at and say, done right. I believe instead of the existential threat, we should be talking about the existential opportunity to engage everyone in moving healthcare to a much higher ground than we are today.
So I want to encourage people, if you're in the audience and you want to ask a question, please go ahead and queue up your question. We will ask it. But while you're doing that, Tom, let me ask you this. You mentioned soft skills in one of your answers and the role of the C-suite. One of the things the C-suite has to do is provide psychological safety. So both the people on the line and even clinicians and even highly paid clinicians can look and say it's something that the way you've planned it may not be working right, and they have the power to speak up and not feel that they'll get the proverbial hand slapped. How do you suggest and help particularly the C-suite create that type of psychological safety so they can get the feedback they need from the field?
I know a lot. I don't know if I know how to answer that question any better than anyone else. What I would say is, the question you just asked goes back to the issue of culture. And I had a great conversation yesterday with a really great collaborative across many healthcare organizations who are all the safety experts.
Mhm.
So if we look at it, I would relate your question to what we learned over the last 20 years when it comes to reducing errors and improving safety. The first thing that starts with an healthcare organization is creating an environment of trust where if someone's seeing something that's a mistake, that's an error, that's a quality issue, they feel safe in saying, hey, this is happening without fear of retribution. And to me, it's the same thing, establishing something that says, and again, I firmly believe AI is the single largest issue facing us when it comes to the future of work. So if we start there, instead of treating this as a technology issue and say, it's not a matter of whether it will affect your job, your work, it's more a matter of how and when. So if we start there, but again, I'm not trying to in any way bash leadership. Part of the challenge right now with AI, particularly generative AI, is not the new capabilities, but the velocity of change it's driving for everyone. So if you're a leader and you're used to, change happening at a certain pace, just look at what's happened in the last year. It's a huge challenge for any leader. But those are the challenges that if you're going to be a leader, you're going to have to lead in, which brings us back to why Gartner and others are saying there are new hard and soft skills required for the leaders of the future.
Yeah. Carolyn, did you have any closing questions for Tom before we wrap up our section with Tom? And this has been wonderful, Tom. Really appreciate it.
Yeah, really wonderful. Thank you so much for joining us. I do have one last follow-up question. I think one of your recommendations was education towards the masses, towards the workforce. Like, what resources do you recommend, or what paths to education do you recommend to leaders, C-suite, to mobilize the masses? Or if you are part of the masses and you want to learn more, where do you recommend looking for more information on how AI can benefit you?
Well, there's so many things. To be selfless, hacking healthcare by the book. Thanks for the tee up.
You just took away my line, Tom. I was going to say that when we said goodbye, but now.
No, honestly, I wrote the book in part to to hopefully be a guide and kind of condensing what I've learned over a decade of working with leaders. And again, we're all facing the same challenges. This is all new, including let's acknowledge being a real leader is hard, and particularly in a changing environment. But it starts with leadership. It starts with understanding, again, AI is about empowerment. It's not about technology. Many times in my advisory work with large healthcare organizations, it's simple questions like, anyone listening, here's the question: is AI part of your HR plan? Because if it's not, then you're probably not paying attention. The biggest thing on change is not going to be what the technologists do, but with what you do in how that impacts the entire workforce, the entire workflow, I'm having the same conversations with medical schools and nursing schools. How are you changing your curricula? Because if you're not changing it and adapting it right now, you're turning out people who are not going to be well prepared for what's already happening, let alone what's coming.
Let me ask you one other question that came to mind. You talked about the need for support in the C-suite. Uh, is there anything you've come to see in your years of working with C-suite leaders that helps, or what I'm thinking of is a strong C-suite leader or someone who's got your back? Is there anything in your years of experience that would indicate to someone in the field, someone who's got that for you more, or how you can help a C-suite leader develop that?
Well, again, I think it's like anything else. It's being aware, it's doing development. I just did, for example, I'll do a shout out to the advisory board. They just did a digital skilling workshop in California. They had 50 executives from all over, things like that. I know we're out of time, but Anonymous just did the concern about misinformation hallucinations. Great question, great issue. This is where maybe it's another episode, but no, absolutely. In talking and championing this, everyone's early in the journey of AI, particularly the stuff called generative AI, which just came screaming at us in the last year. We clearly need to be looking at the opportunities, and to Anonymous's point in question, making sure we're putting the appropriate guardrails on, so that at a minimum, it's doing no more harm than what we're doing today, and hopefully better. But there have to be guardrails. But I would also say, it's not just guardrails, but looking at both sides. It's the what are the threats, but what are the opportunities? And I do whole courses on decision making, but to this point, there are a lot of good things that, like generative AI is showing it can do, like create clinical notes in formats like SOAP and be highly accurate. But there are a lot of things that it can do, but the human has to be in the loop as the ultimate, to be looking at, okay, this is useful, but then you are the one, as a nurse, as a doctor, as a rev cycle specialist, you're the one that ultimately is making a decision. It's how do we bring things in behind you to make you better at the things you care about? That's the issue. But thank you for raising that issue. It's an extremely important issue.
Well, Tom, thank you very much, and I will second Tom's recommendation of his book. Obviously, why we have Tom here. Tom's an excellent resource, and I think Tom was a little, self-facing when he didn't recommend, following him on LinkedIn and some of the other things he's done on Twitter. Great resource, and I'm sure we'll reach out and have Tom back. Well, thank you very much, Tom. I know you.
Thank you very much. Appreciate it.
Okay, and have a wonderful rest of the day and a wonderful weekend.
Thank you, Tom.
Thanks.
So, Carolyn, do you want to move on to the quick takes? And actually, I apologize. I should move on to the quick takes. It's been one of those days, folks. So bear with me.
I would love to hear your quick takes. Let's take it away.
So a couple of quick takes on stories that have been broadly covered, gotten a lot of news coverage. I'll just give you some of our views. Mercer did a survey that employer benefits, costs are going to rise over 5% next year. This is the first time that costs have been over 5%. They've been 3 to 4% in the last decade. This is driven a lot by expensive drugs like the GLP-1s. We would expect to see more cost management, prior auth and things like that for the GLP-1s. This has been a recurring theme for us. We may be on the outside a little bit there. I would say the other thing that was really interesting about the study is over 40% have expanded their behavioral health usage. Of employers have expanded behavioral health usage in the last 3 years. Really great to see. Medicare Advantage growth, this was an article in Health Affairs, has been fueled by people switching from original Medicare. Medicare beneficiaries, fee-for-service beneficiaries that have switched to Medicare Advantage has more than tripled between 2006 and 2022. This has been especially younger and healthier patients. this does have some implications for Medicare overall, because if you switch after the open enrollment period, it does have implications for risk management. One issue I would say to be wary of is risk management and risk adjustment will be an issue because of this, and that could bring greater focus to some of the things that some of the plans are doing with risk adjustment and upcoding. So keep an eye on that. Thoma Bravo, the private equity firm, bought a healthcare software company, NextGen Healthcare, in a take-private deal. Ambulatory service company, NextGen. Thoma Bravo, very much experienced at software companies. Big boost in PE activity in health tech here. It's up 43% year over year. I would expect both the size and pace of PE activity, not just in health tech, not just in software, but to rise rapidly. A lot of money on the sidelines. Google's medical AI chatbot is now being tested in hospitals. The Verge had a story about the chatbot. Google's based on Google's MedPalm 2 LLM being tested at Mayo since April. It's being used primarily in non-clinical applications such as doctors drafting notes in response to patient questions and also as follow-ups. We would expect that these non-clinical applications, non-high-risk applications will expand first, followed by the clinical applications, and that's some of what Tom has been talking about. And last but not least, cardiovascular disease and health tech was the subject of VC Market Snapshot by PitchBook. And they have raised over $20 billion, VCs have, for cardiovascular disease since 2020. They're on pace to raise about $3.5 billion this year. I would expect here too that this will continue to grow both in size and scope as you see more firms looking at congestive heart failure, hypertension, and ways of controlling this with remote patient monitoring and looking for ways to help decrease readmits because it's very expensive readmits. And with that, I will introduce the first article we're going to talk about, Carolyn and I, which is that there is a story about Walmart having an interest in acquiring ChenMed, the Medicare Advantage primary care provider, and MSO. Any thoughts on that, Carolyn?
So just to confirm, they have not purchased ChenMed yet, but they are interested in this acquisition and maybe approaching that next step forward. Correct, Jeff?
Well, I'm going to do my best David Faber from CNBC and say, as far as I know, with my limited channel checks, they have not actually purchased it. But yes, they are interested in purchasing ChenMed. And I think at first it was a little bit perplexing, honestly. And then the more I thought about it, it makes a little bit more sense in that this would be a bit of a shift and a bigger lift for them, but also a bigger footprint for them in healthcare. This would be them acquiring the primary care clinics. It in part, I think, is a way for them to block other, non-traditional players such as Amazon, CVS, and even Walgreens Boots.
It did seem like somewhat of a response in a way to the other those other retailers who have been acquiring similar businesses and primary care practices, like with Amazon purchasing One Medical and CVS acquiring Oak Street Health. Like this does feel like a step in that direction where they're trying to move towards established, like an arm of the larger company that has established primary care.
Yeah, and I think the difference is to me, this is less of a new, company kind of coming out of nowhere like One Medical. This, ChenMed's been around for a while. The opportunity for ChenMed, I think, was right. Family owned, family run until very recently. And so that, kind of, allowing for Newton's law, anything that's in motion will stay in motion. And I think the other thing is, Walmart has been, trying to do more things in healthcare. The other thing that's very interesting is once you get people through a kind of clinic or a primary care site, at Walmart, you need to get them into a consistent primary care doctor and a consistent ecosystem. And I think, working through the primary care doctors and the MA model at ChenMed will do that. I think the other thing is this, gives them a bigger foothold, with an existing patient base. So it's not only appealing more to that. And one final thing would be, there are Walmarts in places where there are just not available primary care doctors. So this expands the ability of people to access primary care into places, where they didn't have it before. As I've told, many of you, my son was a reporter in a small town in Louisiana. Shout out to folks in Monroe, Louisiana. Go ULM Warhawks. And they have a small hospital there, but they also have 2 Walmarts. So a chance to increase care there. So
And
that
I
would be big.
and that must pair well with Walmart's other acquisition from a couple of years ago, MeMD, that telehealth provider. If they're looking to expand access to primary care in these kinds of rural or more remote locations, having that telehealth platform on top of a primary care provider access network, that should pair well jointly to be able to expand that reach.
Well, it does. The one thing I will say is there are certain issues, and once again, bringing up my son's experiences, there are places where you can't get, broadband and cell phone access. So that's one thing that they will have to look towards is there are, deserts. So in a part of Louisiana where near where my son was, but not where he actually is, they're working with other public grants and other public systems, both in education and in health, to create broadband hotspots, in this case at libraries. So the libraries act as a place where students can access broadband for school. People can come in, get visits. Sometimes they do storage forward, but you have to look at the places where people can't get broadband access. And this discussion for another time, but having a cell phone and having a personal hotspot on a cell phone is not broadband access, and we can talk about that another time. One other thing I did want to bring up before we go to your questions, and hopefully there'll be some more questions, is there was a meeting on Capitol Hill yesterday, the first of Congress's so-called AI summits. This was first of 9, sponsored by Senator Schumer. This was very heavily attended by industry. It was an invite-only event. About 22 people. Very interesting. Any thoughts on AI regulation, particularly in healthcare, Carolyn?
I think this is going to be very interesting. I am someone who's pro AI, so I think it will be good for the general healthcare ecosystem. I think the masses often think about, oh, if I'm going to go receive care and AI is in play, like I'm going to be putting in symptoms to a robot, or I'm going to be, working with the AI and being removed from a provider, and one step away and pulled from that person-to-person care. In reality, I think that as we start applying AI into the healthcare industry, as we talked about earlier, I think we're going to be looking for places where the AI can do better than the person and remove some of the manual work and labor from the person to be able to have that face-to-face interaction. And I really hope that as they think about regulations, they think about it from that approach, how do we get better person-to-person care and kind of remove all that typing in the EHR and all that manual stuff that AI could do to free up the provider's time to give that, more person-to-person, face-to-face experience.
Yeah, no, I think that's an excellent point. I think sometimes what happens from both the technology IT side of the provider and even the payer, and from the sometimes from the clinician side, is they look at the technology and say, it's going to do this and eliminate these things, and that's going to help us. And the patients look at it, as we talked about, and patients look at it and say, it's going to put something else between myself and the provider, or and the clinician. And I think the key is helping to educate patients how what you're trying to do is remove the routine administrative typing into the EHR, prescription list, things that are just, redundant, helping the check-in process be more efficient, answering your questions that are, that don't need the specific, physician input, and then giving the doctors more time to spend with you, with their head out of the EMR. And I think that's important.
Definitely.
One other take I will say, on this is that this is the first of 9. Congress will be going back to school. They will be going out to Stanford for an AI boot camp, is my understanding. And, they will be getting, specific instruction in terms of healthcare, use of AI in healthcare. And one thing I think you see is, of the 22 people, there's a large number of people from industry. And I think what you're going to see is a lot, to the chagrin of some, a lot of industry input into what's going on here. And I think that's important, because I think, one of the mistakes we made, frankly, with the HITECH Act is we checked a lot of boxes, but now we're stuck with EMRs that I think don't necessarily do what we want them to do in terms of helping us in clinical care. And I think we need to make sure with AI that we don't just check boxes, but we bring the best of AI to clinical care. Anything else at the moment you wanted to talk about on that, Carolyn?
I think that was all I had. We haven't learned much around the specific topics or, what they're actually going to be diving into in these sessions. And I think we should circle back to this as a future topic, as we've learned more about what those outcomes of these sessions are, because I think there will be a lot of meaty stuff in there as they start, publishing what has come out of those trainings and those sessions.
Yeah. No,
question from the producer. Question from the producer here. Yeah, because the audience, they are all here still, so but they don't have any questions, but I do, particularly on that last point you were making, Jeff, about sort of trepidation around the industry, maybe helping define some of this regulation. For me, it seems like an open question of we really don't know the potential impacts of AI, and it seems very early to try to regulate it without knowing where it's going. And I loved your example around the EHRs and how regulation may have inadvertently gotten in the way of the end goal there. And then I think, and this is no secret, the potential industry behemoths right now, or the people that really have a jump start on AI, have the opportunity to kind of shape regulation to help entrench them further. Or what's the best possible outcome of those talks from an innovation standpoint, where we kind of are able to still keep the horizon wide open, but meanwhile protect, I think what we're probably all most concerned about is privacy and the other things we might be concerned about.
I think there has to be, and it's very difficult, I think there has to be a balance, because there are going to be certain situations where we may have to sacrifice some privacy for some public good, and that's been a very contentious issue here recently, as we saw with masks. I think the other thing is there are certain areas where we have to be able to regulate iteratively and very quickly. And I think we risk the idea of being perfect versus being getting good enough. And by that, the example I'll give is we've been working with so-called adaptive AI regulations at least 3 or 4 years, and we still haven't come up with an informed consent, a true informed consent policy as to AI models, particularly generative AI models, are going to learn. And that may change the algorithm in a medical device or an app. And so how do we handle that? Are we just notifying the doctors? Are we notifying, we're requiring the doctors to notify the patients? Are we requiring the, AI apps to file a new 510K or the devices to file a new 510K? So all of those things I think we have to look at. I think it's important that we keep, in the front of our minds that we have to be as transparent as possible, which means that we have to tell the patients what potentially could happen, and not mislead them. That there could be a privacy risk, and there's this we talked about, I think last week. There's state-sponsored terrorism going on. There's a very large potential that people's data privacy could be revealed. The question is not what you do, to me, not what you do to protect it, but what do you do? How are you prepared once that's revealed? And how do you make people understand this is what you're going to do for them? There's some talk among some people of actually paying people just a cash, a remuneration. If XYZ happens, you'll get this. If ABC happens, you'll get this. I don't know if that's the way to go, but I think we just have to make sure that we are prepared for these things, and that we have the right preparations in place to limit the damage that's done. I hope that answers your question, David.
I think so. Yeah, I'm super interested in the regulation component, and I'll be following it closely.
One thing I will say, and I see a couple things is we're going to have a very interesting guest from Synapse next week. Please do join. I also, anyone who is on the call now, please subscribe to come back next week. We will have in the future working on getting some people from Capitol Hill to talk about the role, both from the right and left, about the role of DC in regulation, and working on that, and we'll have some very interesting people to talk about that, and we also have some wonderful AI guests coming up. We talked about Mayo and the chatbot. I think it's what is it, October 5th, David? We have John Halamka coming up.
There you go. Yep, October 5th. It's going to be a banger.
Yeah, John unfortunately will be recorded, but John is a wonderful interview. So we have John Halamka from the Mayo Clinic platform coming up. Any questions out there, folks? Please don't be shy. Well, seeing none, please feel free to reach out to me, and you can reach out to me through LinkedIn. Please feel free to reach out to me at Diagnosing Health Tech at healthcarebullpen.com. Please follow us on LinkedIn, Healthcare Bullpen on Twitter. We do a number of blogs on thought leadership. Next blog will be on AI and radiology. Done a ton of blogs on ethics and AI. Our job is to help both you as a health tech provider figure out how to place your technologies and how to navigate selling into health tech. And on the other side, helping healthcare organizations figure out how do you figure out what's the technology you need to do what you're trying to do, what technology is out there and what's the right one for you. So I'll thank you all for joining us today. And with that, I'll turn it over to Carolyn.
All right. Thanks, everyone. You can also follow me on LinkedIn. I'd love to connect. And I will put in one plug for a webinar later this afternoon at 11 Pacific. Redox is hosting a webinar about the healthcare integration jobs to be done. So Brian Matsura and myself will be talking through all the different pieces that you need to construct the healthcare integration. And if you're interested in that at all, we'd love to have you. We'd love to see you there and answer any of your questions. Well, and thank you again, Jeff, for having me.
Oh, thank you for subbing in at the last minute, Carolyn. I really appreciate it. I appreciate everyone's patience today. Have a wonderful weekend.